The next talk, we move gears a bit. So we had electrophysiology. The next thing is now muscle MRI and ultrasound. And for muscle MRI over the past years, there's really someone who completely stood out of the community because he's really the one who transfers the clinical situation into the imaging situation very well. And that's Jordi Diaz-Manea, my dear friend and colleague from Newcastle, formerly from Barcelona, and we still share the interest in football. So Jordi, the stage is yours. Thank you for coming.
Thank you very much for the introduction, and thank you for inviting me again to talk about one of my favorite topics, as is muscle imaging. So these are my disclosures. None of them are related with the content of this talk. And well, you know that we have many different muscle imaging modalities that we can use with our patients. And today I'm not going to talk about CT scan or gammography, but I think that we need to mention them because these are also options that you have in your hospital. So today I'm going to talk mainly about ultrasound and also MRI. And I always start my talks with this slide that I think it's really important because I want you to change your mind. We are not talking about now muscle symptoms, we are not talking about muscle function, we are going to talk about trying to identify what's going on with the muscle structure. So with imaging, we focus on the processes that are happening in the muscle of patients. And it is important to understand what can we find there. So that's the reason why I start with this, because imagine that we have a muscular dystrophy where there is a protein that is lacking, and then we will start with a muscle that can be relatively healthy here. So I don't know where I have to point, if I have to point here or here. Sorry? Oh, that's going to be easier, right? Yeah. So imagine that we have a muscle that lacks a protein, then this is going to produce some muscle injury. We're going to have muscle fiber necrosis. We're going to have inflammation and loss of muscle fiber. So in this first stage, what's going to happen is that with inflammation, we are going to have an increase in the amount of water in the muscle. And this is what we want to detect, the presence of water, which is edema, which is linked to inflammation. In a second stage, what we are going to have is loss of muscle fibers and replacement by fibrotic and fat tissue. And this is more a chronic status of the disease, and we can try to identify this fat and fibrotic tissue with different imaging modalities, as you will see later. So having that in mind, let's start with ultrasound. So ultrasound is trendy, that's a reality, is gaining popularity. There are many people that are starting to use ultrasound in their clinics, and there are many reasons for that, of course. And the main one is that it's not invasive and cheap, so you can have a portable device now that you can connect to you can plug it to your phone, for example, and you can just explore your patients while you are doing the clinical examination in your office. So can be descriptive of the findings, but can also be quantitative. I'm going to talk about this a bit later. And then we start to have scanning protocols that are standardized for specific muscles. And in general, there is a good correlation between the changes in the echo intensity and the fat fraction, which is a concept that I will explain later, of the corresponding slice on MRI. So it has been proposed as complementary to MRI, and I think it is a useful tool that can be, as I said, used in clinics. And just to put you here some images of echo, here is the so-called Hetman score that is showing you the progression of fat replacement in a muscle and how you can see that. And I think it's very clear that you can see where the more fat you have, the less you lose a bit the appearance of the muscle, you lose all this trabecular tissue, and because in the end there is less muscle and there is mainly fat. So Hetman score have one problem, and is that is for me at least, it's still semi-quantitative, so it's very observer dependent. And for that reason, there are several groups trying to work in converting ultrasound in a pure quantitative method that allow to follow up patients in natural history study or in clinical trials. So there are some groups that are trying to get images from the echo and analyze them with different softwares like ImageJ to quantify the intensity of the pixels and to give an idea of how much fat it is present in the muscle. There are some other issues, for example, that the amount of fat or the features of the muscle can change depending on how you put the proof, and of course this requires training and understanding of what you are doing when you try to quantify the amount of fat in the muscles of the patients. So the main advantage for me is that can be used in patients that cannot perform an MRI, like babies, children, patients that are, for example, in the intensive care unit, connected to a ventilator. Is easy to use, as I said, as a first step in clinics. Can also be used for some muscles that are difficult to assess with MRI, like facial muscle or abdominal muscles. Is potentially sensitive to detect fibrosis. This is something that I always like to mention because fibrosis is one of the things that we cannot detect with muscle MRI yet. It's relatively fast, depend of course of the number of muscles that you want to assess. The more you want, the more time that you need. And it's sensitive to change, as I said. There are different scores that allow you to follow up the progression of the disease, but have also some drawbacks, of course. So I am not sure that ultrasound can detect edema when this edema is not massive, when there is not like a massive destruction of the muscle, so when there is just mild. But I would like to discuss this with other people that are more expert than me in ultrasound. Can be influenced by the amount of subcutaneous fat. So in patients that are obese, of course, accessing to the muscle can be difficult, and then it's limited to superficial muscles. And if you want to quantify the amount of fat and use it as for the follow-up of patients, it requires some training. So you need to be trained, and there are not many trainers, I would say. There are just some centers that I know, for example, in the Netherlands, that can offer this training. So, and then the reproducibility of quantitative ultrasound needs to be demonstrated further, in my opinion. But as I said, useful tool, very interesting for assessing patients in clinics. So I'm going to move now into magnetic resonance imaging. So as we have mentioned before, this is the original slide that I put at the beginning. So if we want to, one of the good things, what I like the most about muscle MRI is there are many different sequences that we can use. Some of them are very well established in all the hospitals, so easy to access for everyone. Others are more research sequences. I'm going to talk a bit about all of them. So, but if you want to detect the presence of necrosis or inflammation, there are some sequences that will allow you to see the water, to see this increase in the water content, like for example a stir. And you can see this increase in the signal in some of the muscles that are inflamed in these patients with inflammatory myopathy. So easy to identify what muscles are inflamed. And if you want to see fat, there are some different sequences like T1, for example, or Dixon, that will allow you to see how fat is replacing the muscle, and you can see this white tissue again affecting different muscles in a patient with a muscle disease. So we have two different sequences that are specific of some of these changes. So why do we use MRI? So we use MRI for many reasons. We can use MRI, for example, to identify a good muscle for a muscle biopsy. You have a patient in front of you with an hypercicemia, for example, and you detect a muscle inflamed. That's a good muscle for the biopsy. Or the other way around, if you have a patient that is in a wheelchair and there is a lot of muscle atrophy, you want to be sure that the muscle is still there. Muscle MRI can also help you to find that muscle. Pattern recognition, I'm going to talk about this a lot. It's another of the reasons why we use muscle MRI to identify patterns that can help you to diagnose patients, as a biomarker to follow up patients, and also as a tool that can help you to plan the care. And this is also important when you have a patient in front of you and you are going to give some advice about what exercises this patient can do or what are the expectations about in front of a new treatment that is arriving, to have an idea of how other muscles, what muscles are gone, are really, it's a really valuable information. So that's another reason why we do MRI. So let's talk a bit about pattern recognition. So pattern recognition is based in the fact that muscles are affected in patients with different genetic diseases, but the way how these muscles are affected is not random. So depending on the disease that you have, where you have the mutation, there are some muscles that are going to be affected first, and others that are going to be affected later. So for example, you have a patient with a mutation in the calpain gene. This patient will start probably with an involvement of the posterior muscles of the thighs and the gluteal muscle, and later on will have an involvement of the quadriceps. While if you have a patient with a dysferlin, it's going to be the other way around. Probably this patient will start with involvement of the quadriceps that will affect later the posterior muscles of the thighs. So this combination of changes that you can see in the MRI is what makes, or what we describe as a pattern. And for the last 20 years, there have been many, many papers describing patterns, saying this pattern is specific or characteristic. You can find them in the literature. There are a lot of reviews, but this is what we call pattern recognition. So in front of an MRI, identifying these changes that allow us to diagnose a patient. And just to put you some examples of patterns, because I think it's always good. So when you have an MRI in front of you, what can you do? So not only look at the muscle that are affected, start by looking at the texture, so how the muscle is replaced. And you can see here an example of what we call the diffuse pattern, where all the muscle is completely substituted by fat, and there are no differences in the amount of fat present inside the muscle. This is what we see in muscular dystrophies, which is slightly different to what you see here. This is what is called the frosted glass, and this is what we observe in patients with congenital myopathies. So if you see these differences in the texture, you can think about a congenital myopathy instead of muscular dystrophy. So this is a completely different pattern. I'm pretty sure that you can already identify that this is not similar to what we have seen in muscular dystrophies. It's what we call the reticular pattern, where you have these trabeculas and inside the muscle that are being increasing in size until we arrive to later stages of the disease, where you still can see small areas of muscle that is not affected. And this is what we call the reticular pattern seen in neurogenic diseases, very specific of, or very characteristic of patients with Charcot-Marie-Tooth or spinal muscle atrophy. And then there is another pattern, what we call the patchy involvement, which is also seen in patients with neurogenic diseases, where you have these big islands of muscle that are substituted by fat and areas that are completely normal. And this patchy involvement is seen, as I said, in neurogenic diseases, but also in other myopathies like valosin-containing protein disease, or also in some glycogenosis. So just talking about another thing that you can look at is the symmetry. So there are some asymmetric diseases in the clinics when you do clinical examination that have also their counterpart in the MRI. So if you look at the MRI, you can identify asymmetries, for example here, typically in FSHD, but you can also see asymmetries in carriers of mutations in the dystrophin gene or in inclusion body myositis patients, right? So in FSHD, it's characteristic to have an involvement of the periscapular muscles and abdominal muscles. And even though this is a muscular dystrophy, it is very common that you see inflammation, like what we see in patients with inflammatory myopathies. You can see here an austere increased signal. And muscular dystrophies, of course, they have typically involvement of the muscles of the limb girdle. So either in the upper or the lower limb girdle, you can find severe replacement. And I don't want to go into too much detail on the different patterns that you can see in all these muscular dystrophies, but I think it is important that when you have a patient in front of you that has a prominent involvement of the gluteal muscle, the pelvic girdle, the quadriceps, the posterior compartment, muscular dystrophy, it's an option, of course, a limb girdle muscular dystrophy. And even if we talk about a disease that typically affects the pelvic muscles, these patients tend to have distal involvement as well. So patients used to have involvement of the gastrocnemius muscle, involvement of the tibialis anterior muscle, etc. And then this is just to show you some congenital myopathies here. In front of you, you have two different diseases with some examples on the MRI. And you can see, for example, the typical pattern in rear one, where there is an involvement of all muscles of the thigh, except the rectus femoris and the adductor longus. And here you have this prominent involvement of the soleus with the texture that I was just mentioning before, where you can see that it seems that the muscle is not completely replaced by fat. And there's another important group of diseases that we can identify with muscle MRI are inflammatory myopathies, which are characterized by inflammation. And therefore, the main thing that you are going to see is an increase in the water content that tend to be diffuse with a typical pattern. Because as you know, inflammatory myopathies tend to be proximal, tend to lead to proximal weakness. The typical thing that we will observe is that there is an increase in the stir signal in the proximal muscles of the lower or the upper limbs. This is a patient with a dermatomyositis, for example, and you can see that stir is widely increased in many muscles. The quadriceps, for example, in this coronal slide, you can see that is all along the quadriceps muscle. Sometimes it's also subcutaneous or prominently perifascicular, but in general, there is no fat. in these patients. So it's mainly a stir. And when we have fat, is when these patients have not been treated adequately or are not responding to the drugs, and they have more a chronic stage of the disease. But this image is just to show you that MRI can also be used in patients with inflammatory myopathies to follow up the disease, the response to the treatment. And you have a patient here before and after treatment, and this is the T1, there is no fat, but this is the stir, and you can see that before treatment there was an increase in the stir signal that was reduced or absent 3 years later when the patient was treated with steroids and was completely fine. And then it can be also useful to diagnose patients with IBM, and this is a patient where you see the typical involvement of the quadriceps that we see in clinics with a gradient from distal to proximal. This is a very nice image where you can see the coronal slice. Distal section of the quadriceps is gone, while the proximal is still fine. But because this is an inflammatory myopathy, the stir is very increased. So when you see increase in a stir, think about inflammatory myopathies, but take into account that in some muscular dystrophies like FSHD, dysferlin, you can also have an increasing signal in the stir signal. And this is just to show you that we have, Benedict was talking before about the flexor finger weakness of these patients that of course has a counterpart in the MRI, and you can see a fat involvement of these muscles in the arms. So good. This is very nice, and I could be here hours and hours and hours talking about the different patterns of many different diseases. Probably in 15 minutes you would start thinking about what you are going to do this afternoon. That Prague is very nice, what I'm doing here. And the reality is that I have the same feeling than you. So for me, when I'm in front of all these patterns that are described, it's like being in front of this nice picture of hundreds of different leaves and trying to remember the size of the leaf or the shape of the leaf. And this is my face very often when I try to remember all these different patterns. It can be very hard. And the reality is that, as Benedict said, I am interested in people using MRI. So some years ago, I started asking my colleagues, do you use MRI for clinics? And most of them were saying, yes, it's very nice, but I don't understand the changes, or I don't remember the changes. So no, we don't use MRI for diagnosing patients, or just occasionally. So we try to find, how can we help people? Is there a way we can help people? So we started this project with Jose Verdu, who is an informatician working in our team, and we decided to try to use artificial intelligence to predict the diagnosis of diseases using the information present on MRI. So we collected a lot of MRIs. We analyzed the amount of fat using different scales. Mercury scale was mainly used here, and quantifying the fat in different muscles. We built a model, an artificial intelligence model based on machine learning, and then we built a predicting tool that at present is able to predict the disease with a high efficiency. So this project that started as something small some years ago has now grown, and we have a huge network now of people that are sharing MRIs with us. You can see that we have collaborators around the world, and we share these MRIs using this tool, MyoShare, that has been built by Jody Warman in University of Ottawa, that allow to share MRIs between different research groups in a safe way. And what we have been able to collect is 3,500 MRI, more or less, of 3,000 patients with 39 different neuromuscular diseases. So we have been able to build a model that can now predict 20 different diseases, the most frequent ones, with a high accuracy. So our last run, we were able to have an accuracy of 75%. So this means that the algorithm is going to predict a list of diseases, and if the first prediction is correct, that happens in 75% of the cases. If the three first predictions are correct, that happens in 91% of the cases. Of course, depends on the disease. There are diseases that are more hard to predict for the model, but this is the global accuracy. And this model is now on a web, which is open and free for everyone. So if you go to myoguide.org, here there is a tab that says diagnosis. You click there. You just need to have your MRI close to you. Then you will find these different diagrams, and this is a GIF. What you can do is that you put your mercury score there. You just need to click the muscle, and then with the mouse, you can just select. The good thing of working with young people is that they can do fancy things. So if you don't like the grays and you prefer greens, you can change that color, or you want pink, you can change that, of course. And then once you have done, you click submit, and in a few seconds, you will have your result of the prediction. Remember, this is a predictive tool that by now works with 20 diseases, but is open and free. You just need to register in the web. So, another important concept is MRI used as a tool to follow patients. And I think that's changing the way how we understand MRI. So far, we have been talking about MRI as a diagnostic tool, but now I want to talk about MRI as a follow-up tool. So the reality is that in the last years, there have been also many publications about software that allow us to quantify the amount of fat. That is not our eye. We have a software that can tell us the exact number of pixels that are fat are these ones, and this is Dixon. So Dixon has the power to separate water and fat. We just analyze the amount of fat, and it can tell us that in this patient, at baseline, it was 49% of fat, and now 1 year after, there is 51.2, so a difference of 2%. Okay, so this is something that our eye will never be able to do, to identify changes of that range. So with Dixon, you can. And in the old times, so I can tell you that I have spent many hours of my life just drawing regions of interest, which is drawing the muscles in an MRI to do these nice research studies where we wanted to use MRI to follow patients. So we used to select some slices, identify the muscles, draw them, and then with what we call manual annotation, and get the amount of fat, and with this we were able to provide detailed description per muscle, or with what we call the mean thigh fat fraction, which means the mean result of all the muscles of the thigh. And of course, we can also have information about the volume and the amount of muscle that is left, what we call the contractile cross-sectional area. So these studies have been done for years, and they have demonstrated that are sensible to changes over a short period of time in many muscular diseases. This is just an example of Duchenne, where you can see that the fat fraction was significantly different from baseline to year 1 in a group of patients. But there are studies in Pompe disease, in muscular dystrophies, in FSHD, IBM, etc. And not only short period of time, also long period of time. Patients in some studies have been followed for 6 years, 10 years in the COSA study, showing that in general the rate of progression is similar. Here it's our study in Pompe, where we observed that there was a rate of increase of 2% per year, more or less. And of course, after some years, our eye is now able to see that there are some differences in the muscles. You can see here the C, and you can see 3 years after there is a bit more of fat, easy to identify. So quantifying muscle, the fat fraction in muscle has some advantage, of course, and I'm going to put these videos that are nice. So the main advantage is that it gives you an idea of the amount of fat that is present, and this is purely objective. It's the truth. This is the amount of fat that is present in the MRI, or the number of pixels that we consider fat. And then allow us to investigate, for example, how is this fat distributed, and you can see here, and you can see in this Sverling, for example, the fat, which is yellow here, is mainly in the distal area of the muscle, closer to the tendons. This is BCP, where you can see that the distribution is completely different. It's more lines that go from one part of the muscle to the other, and then allow us to also try to understand why there are these differences in the progression of the fat changes. But there are some limitations, and for me, the main limitation for its use in clinics is that it's time-consuming. So I don't know how many of you want to spend 6 hours every afternoon drawing regions of interest in the muscles of their patient just to know if there is a progression. Or for example, now that we start to have treatments, imagine that you put a treatment and you want to closely follow up that patient. Do you have 6 hours? You want to spend your Saturday on that? So that's, of course, no. And then one of the main problems that we have is the lack of automatization. So What we have done, and it's not only us, there are several groups, is that we have been able to develop a tool that can automatically segment the muscle. So it identifies the muscles, and it quantifies automatically the amount of fat. So I think that this is going to change the way how we use MRI in clinics, because with these tools now we can have all our muscles segmented, and not only 5 slices. We can use 20 slices. And maybe you have not seen this, but with the tools, you need 1-2 seconds per slice. So I used to spend hours. Now, when I saw last week that we can segment an MRI from pelvis to the toe in 25, 30 seconds, I said, okay, oh my goodness. So these are changing, and this is good, because you can start using this MRI in clinics. You can start applying this to your MRIs and quantify the amount of fat. And this is good because it correlates with the muscle function of the patient. So you will have a measure, fat, that has been demonstrated that correlates very well with the results of muscle function tests. For example, here's a correlation between the amount of fat and the 6-minute walking test. So the more fat you have, the less distance the patient covers in that test. And here there is another table showing correlation between muscle fat and many different many different outcome measures that we use in clinical trials or in our clinic. So fat correlates well. So having fat in the muscle, of course, is not good for patients and correlates with muscle function. But not only correlates, it also anticipates what happens, because we see changes in fat earlier than what happens in muscle function. And I want to show you this patient, which is a patient with Pompe disease. We started treating this patient in 2016. 6-minute walking test at that moment was 282 meters, and this is the way how she walked. And fat fraction at that moment was 32%. Okay, we started ERT. Remember, Pompe disease, we have 3 ERTs now, so we can change one treatment for the other, and then we need tools to follow up our patients. So this is the same patient in 2019. Some of you could say, oh, I think she's worse. This pattern of walking is not the same, or maybe it's the same. But if I use 6 minutes walking test, it's the same distance. It's 277, 5 meters less. So is this significant? Probably not. But in the MRI, there is an increase of 6% already in the amount of fat. Okay. Now I move to 2023, and there is a substantial change, right? What is the change? She's using a cane. She has pelvic, he feels imbalance. But the distance she's covering is 264, which is just, I think, 18 meters less than 8 years or 7 years before. So is this significant? I don't know, maybe yes. But if we look at the MRI, there is 48% fat fraction now, so 18% more. So would you change your ERT? Would you offer a patient a change? Based on the 6 minutes walking test, maybe not, because this is just 18 meters, maybe, I don't know, Benedict, would you offer that? It's difficult to say, but if you have something that can help you to take this decision as MRI, of course you can build a story. Patient is doing worse with the muscle function test, and I have an objective measure, that is MRI, that is showing that the muscle is losing, being lost, which is not good for patients. So MRI can be useful, of course, in your clinics. So this is chronic damage, but we have now new treatments that are arriving to the field that can also change things earlier. And we want to see these early changes, right? We want to put steroid to our patients and see that there is a decrease in the inflammation. We have now gene therapies. What happens with the acute changes? Do we need to wait for fat, or can we identify changes earlier? So yes, we can, of course, because we can quantify the amount of water using water T2, which is a measure that can help us to understand how much water is present in the tissue, because we look at the time of relapse of the echo in the T2 sequences. What we need to do is to draw again a region of interest, and this will allow us to identify the water T2 here. And it is known that in muscular dystrophies, in inflammatory myopathies, water T2 tend to be high. And I always put this paper because I love it. It's a paper where the researchers investigated water T2 in patients with Duchenne that were starting steroids. And they could see that just after 3 months of putting steroids, water T2 decreased. So they could see an early change and an early effect of the muscle, of the treatment in the muscle. And not only that, they follow patients for 1 year, and they observe here that those that were taking steroids did not change too much the fat, but those taking steroids increased the fat considerably. And not only that, water T2 can also predict changes in muscle function. This is a study that we have done in Newcastle, where we have observed that patients that had high T2, that are, for example, these ones or this one, had a decline in muscle function much more substantial than those patients that had a lower water T2 that are just represented here, suggesting that if you are in front of a patient in your clinics, and the patient tells you, doctor, what's going to happen with me next year, or in 2 years' time, in 3 years' time, what do you say? It's difficult, right? For me, it's very complex, this question. But if you have an MRI that shows that this patient has a very high T2, we start to have things that can help us to give some advice. So it seems that this patient can progress quicker than others. And this is also useful for clinical trials, because you want to include in clinical trials patients that are going to progress, to see if there is an effect of the drug, no patients that are stable. So water T2 is showing some promising results, even though I accept that this needs to be confirmed in many more diseases with many more patients. But there are other things that happen earlier, and we know that when there is a hole in the membrane, there are changes in the different, in sodium, in potassium, changes in the pH of the muscle fibers, and this is more research, but it's also hopefully arriving to the clinics, because we can try to use these sequences to detect changes. So this is a spectroscopy. So with a spectroscopy, as we do in the brain, we can identify different components of the muscle. So phosphorus spectroscopy has been used for years to identify changes in the ATP, and in the 90s and early in this century was very trendy in patients with metabolic myopathies to distinguish between mitochondrial myopathies and glycogenosis and other diseases. But it also provides information about the integrity of the muscle membrane and also about the pH. And there is this nice study where it shows that the earliest changes in Duchenne is that there is a change in the pH that increases inside the muscle fibers. But not only we can use phosphorus, we can also use sodium, and sodium can also give an image of the amount of sodium, and this is something that has been shown to change also very early in the progression of our patients. So patients that are asymptomatic with a muscular dystrophy, if you could potentially use sodium to identify an increase in the amount of sodium in the muscle fibers, and this is a nice picture of patients with Duchenne, where you can see that there is this increase in the signal, and you can see here the muscles of the Duchenne patients that have higher sodium than the controls. And this is a study that we are doing in Newcastle in this Ferlin. This is my leg, and you can see that I hope it's good that I know that I have normal low sodium levels. If you go here, you have to see that the tibialis anterior patients with this Ferlinopathy, and you can see a clear increase in the signal. And just to finish, a part of phosphorus, sodium, there is also carbon spectroscopy that is now getting very trendy, because carbon, you can see all the molecules that have carbon atoms, and one of them is glycogen. This is the glycogen peak. And of course, in Pompe disease, where there is a lot of industry, many companies trying to do trials to demonstrate that drugs reduce glycogen, these tools can be used as a non-invasive method to quantify glycogen. And this is just to show you the peaks that we can find in the patients correspond to glycogen, and they tend to be increased in patients with Pompe disease. So the main limitation, fibrosis, and I want to highlight this, because many people ask me, if I want to study fibrosis, what I have to do. So far, there is not a good way to study fibrosis. MRI, there have been many studies using different sequences, and all of them have failed to demonstrate fibrosis. But I want to show you this nice study done by the group of Ferdinand Nieling in Germany. They have used this new technology called optoacoustic tomography, which is an echo that has the particularity that can identify different components in the muscle, like collagen, lipids, or also hemoglobin that has oxygen. And what they did basically was to study peaks, Duchenne peaks, and then they identified the presence of collagen. You can see it here. These are the controls. They observed that there was an increase in the collagen in the Duchenne compared to the wild type, that there was a good correlation with the amount of collagen in the muscle biopsies. And of course, they applied this to patients. Here there's this picture of a Duchenne boy, and they observed an increase in the amount of collagen, and there was a good correlation with muscle function test. I want to see the longitudinal studies. For me, we think it can be hard to be sure that you are exploring exactly the same region in the muscle, but this technique looks promising, and then let's see what happens. So conclusions, muscle imaging, I think I have convinced you that offers a high range of techniques to identify muscle pathology, useful for diagnosis and the follow-up. Muscle MRI is still useful for supporting the diagnosis of patients, even now that we have next-generation sequencing. Bear in mind that the exomes are not going to diagnose all your patients, and then there are variants of unknown significance. MRI is a tool that you can use, an ultrasound tool that you can use to confirm that the patient has a disease, neuromuscular disease, guide you with the biopsy, help you with the diagnosis. And I hope I have convinced you that MRI is useful for the follow-up of patients, not only in trials, more and more in clinics. And we have, of course, a lot of research, and hopefully we'll have new sequence in the next years. So I want just to thank all the people in the team that are working with MyoGuide. If you are interested, just write an email. Happy to have collaboration, and all the team in Newcastle. Thank you very much for your attention.
Talk again on the topic.
Thank you very much.
Questions over there? We need to have the microphones, please.
Hi, thank you for your inspirational talk. You really have convinced me the clinical value of the trials and also of the diagnostic questions, but not really on the follow-up clinical, because you have a lot of clinometrics in the clinical practice, and you have also the medical history of the patient. So in many diseases, you can think of what's going to happen in the next year, and you can also discuss this with the patient and have precautions for this. How do you think MRI can add to this palette of information you already have in the clinic?
Well, I think one of the important things is that MRI is trying to happens in the tissue that you can detect with MRI happen earlier than the changes that you see in muscle function test. This is what it has been shown in patients with muscular dystrophy, so in patients with Pompe disease, for example. So that's very interesting, because you can see a patient repeat the muscle function test that can give you the same information, but there are already changes that are happening behind the scenes in the muscles that you can detect with the muscle MRI. So for me, it's not a fight here. So this is a tool. It's a tool that you can use in your clinics, or you can use to give you information about how the muscle is progressing. So the reason why I use muscle MRI a lot is because we have observed that the changes happen earlier that have a meaning. So it means that when you have more fat, eventually this leads to a change in the muscle function in the patient. So can somehow predict what's going to happen to the patient. So you have a patient where the fat is stable, you don't see, or you probably can think that this patient is not going to change too much over the next year. If you have a patient where the fat is increasing considerably, you can probably predict this patient is going to have changes. So if you have, of course, now we don't have many treatments, unfortunately, for our diseases. But I think the Pompe disease is a good example. We have 3 different treatments. We can not only offer one. We can change from one to the other. And we need tools, not only our clinical assessment or the subjective assessment of the patient, something more objective that can help us. So that's the reason why I think we need to implement MRI in clinics. But what we need is also tools to allow us to analyze this MRI quickly. And then the segmentation, automatic segmentation tool, I think it's something that is going to change how we use MRI in clinics. I don't know if I have answered you. Good.
But before we go to the next question, so this is really something in this discussion. So what he showed in the first part really was function follows form. And the prospective part is really form follows function. And that's where we have to go to. So this is really the old Bauhaus saying. Of course, then next question here.
Thank you. Thank you for the nice talk. Just to understand, the pattern, for dysferlin, you mentioned the quadriceps is anteriorly affected first. What's the difference in why is that the difference in the affection in different condition? Is that, is there a correlation with the genetic and what protein is affected? Okay. Can you predict that you're going to see this more than the other?
Thank you very much. So that's the $1 million question. Everybody asks this every year. I mean, we don't really know. No one knows why one disease. Imagine that in all the diseases, in theory, you lack a protein in all your muscles, and then in muscular dystrophies, when we explore a patient, they have pelvic girdle weakness. Why? They don't start with tibialis anterior weakness, right? And then the same for the distal myopathies. We don't really know. So it is not known why there are some muscles that are more prone to degenerate in some diseases while others are not affected. There have been lots of efforts trying to understand these people that have been doing muscle biopsies of muscles not affected and other affected, studying them using proteomics or transcriptomics. People that say that probably that the predominance of the fiber type in some that is different from one muscle to the other can be a factor in some diseases, but the reality is that it is not known why.
Thank you. So, I'll ask you another question. Okay. Yeah. So for this, Dixon, technique, which compared to the other, the fat suppression and the water suppression technique, how does it give an additional advantage? And if you got an existing, Philips or Siemens machine, can you add this software onto that?
So the software, the main protocol that we use, which is the T1 and the STIR, that has been used for many years for diagnosing patients. That's something that is available in our hospitals. You can do it in 1.5 Tesla, 3 Teslas, no problem. Dixon is a technique that is used by the people expert in liver. So working in liver diseases is present in most of the hospitals. The problem is that there is not a way to quantify the amount of fat using Dixon because this is not commercial. Philips or Siemens, they will not provide you with a software. But there are softwares, for example, the one that I have just shown, you can find it in MyoGuide, for example, but there are other webs that can also give you some softwares to quantify the amount of fat. So you go to the radiology department, they probably have Dixon already there, because that goes with the pack that Philips or Siemens will install in your MRI. You just need to ask them to use it. And then there are protocols that are published with how to implement this technique for muscle in your MRI.
Okay, yep. Thank you.
That's good.
You talked about fat in muscle. Yep. Now, we have two types of fat in muscle. We have islands or individual fat cells, or we have lipids within muscle fibers. Yep. Can you distinguish this? Can you recognize severe lipid myopathy, which is where the muscles are full of fat, muscle fibers are full of fat, but there are no fat cells necessarily?
No, we cannot. We cannot differentiate between intramuscle fiber fat and extramuscle fiber fat. So in patients with lipid disease, in general, we have a lot of fat in the muscle, but it's impossible to distinguish that, as far as I know, with the techniques that we have from patients that have just fat substitution of the tissue.
Any additional questions? There are no online questions. So may I ask you all, how many of you are using ultrasound or really have learned using ultrasound already? Okay. And I just ask you now, so could this something we adopt to the next WMS, that we do an ultrasound course?
Yeah.
Okay, so we have already something. Thank you. Thank you. Very good. Thank you, Rüdiger. This could be really one of the topics, electrophysiology as well. So that could be 2 extras to the next teaching course and adopted to this, because we always have to look for something new.